Good morning, and thank you for joining us for part one of a three-part series of webinars from Paragon Vision Sciences and Contact Lens Center of Australia. Upon completion of the webinar, we will follow up with an email including an invitation for part 2 and 3. There will also be a registration link for the Paragon CRT contact lens fitting and myopia workshop to be held one day prior to the OSO on Thursday, September 22nd. I'm Angela Kasparik, Practice Management Consultant with Paragon Vision Sciences. I am pleased to be with you tonight and have this opportunity to introduce our guest speaker, Dr. Maria Liu. Dr. Liu is a globally recognized key opinion leader on myopia management. She is a Chinese-trained ophthalmologist who obtained her OD from Pacific University and her PhD and MPH from UC Berkeley. She is full-time faculty with the School of Optometry, UC Berkeley, and assistant professor of clinical optometry. Dr. Liu is also director of the Myopia Control Clinic, UC Berkeley. Dr. Liu will be answering your questions following the presentation. In the event that time does not allow us to answer all of your questions, we will answer them individually via email. The question tab is located on the control panel to the right of your screen. Please join me in welcoming Dr. Liu.
Thanks, Angela. Good morning, everyone. It's my great pleasure to be here and to lecture in part one of this really exciting series of global myopia management. We're going to take some time today and to show you some very, very exciting and interesting data on myopia. So the three subtopics I want to discuss with you today include the burden of myopia from public health and also individual patients' point of view, and also why we want to start treating myopia early, and the relative contribution of the genetic versus the environmental influence of myopia. And if time allows, we're going to give a very brief overview of the currently evidence-based treatment of myopia. So hopefully with this audience, I don't have to convince you that myopia is not just an East Asian problem and it's reaching epidemic worldwide. And the 2 points I want to emphasize here is, one, you can see myopia, the prevalence of high myopia is reaching at a very alarming percentage in many countries and area. And this is partially related to the overall age of onset of myopia becoming younger and younger. And this really means that the overall severity of myopia will be increasing at even higher rate. And that is because the earlier the onset of myopia, the longer duration of each individual kid will stay in this risk window for fast progression. So they're much more likely to end up as a very high myopia and develop pathological changes related to this condition. So myopia can cause significant health burden from a public, at public level and also at each individual level. So if we're talking about the economical burden of myopia, keep in mind that the onset of myopia as compared to most other common eye conditions is much younger, which means from a financial standpoint, the expenditures related to the corrections of myopia and also the treatment of myopia happening at a much earlier stage to each individual patient. And in addition to that, we know it's not just the direct cost of treating myopia. The indirect cost of myopia due to the loss of productivity, the loss of quality of life, and the loss of independence is substantial. It has been reported that for high myopia, prescription worse than -10, its impact on quality of life is similar to that of keratoconus. Additionally, we know right now, myopia has become the most common cause of vision loss. That's coming from a global perspective, taking all age groups and all economical classes into consideration. It's not that there is not one of, it is actually the most common cause for vision loss. However, the prevention and treatment related to myopia is also the most cost-effective relative to other priority eye conditions defined by WHO, which are diabetic retinopathy, cataract, glaucoma, and AMD. Despite that, the government, at least U.S. government expenditure in research related to myopia is much less than those spending on other priority conditions. And last but not least, because of the high prevalence of myopia, not only the prevalence matters, the severity of the condition also matters. The severity of myopia has a very large impact on population disease risk. In other words, if there is a small shift of the overall average degree of myopia into a higher level, and its impact to the disease risk at population level is very substantial. Conversely, if we can apply some treatment that slows down the myopia progression and lower the average level of myopia at a population level, and its benefit to the public health is also very substantial. And that is even without, without affecting the overall prevalence of myopia. If we can reduce the average severity of myopia, it carries a very significant benefit to the public health. So let's take a closer look at how myopia causes vision loss. As we mentioned earlier, if we're coming from a global perspective, taking all ethnicity, all age groups, and all socioeconomical status into account, myopia is actually right now the primary cause of blindness, and it accounts for up to 27% of all low vision cases. And keep in mind that although there could be some interocular asymmetry, vision loss or blindness due to myopia is almost always bilaterally, and it happens at a much earlier age to certain patients, which means its impact to someone's quality of life and the loss of productivity is profound. And so myopia can cause blindness either due to its direct pathological changes related to myopia or its significantly increased risk to other complications. Pathological myopia usually comes either as a degenerative or atrophic maculopathy, or it could be due to tractional changes to the macular area as a result of excessive and uncontrolled axial elongation. And common complications related to myopia include glaucoma, retinal detachment, and cataract. And before we start talking about pathological myopia, I really want to make a distinction between high myopia and pathological myopia. And even though the prevalence of pathological myopia mirrors the prevalence of high myopia quite closely, we should not use the two terms interchangeably. Pathological myopia should be more accurately defined by the clinical presentation of like a classical, typical pathological changes, which is characterized by some degenerative changes in the retina, choroid, and sclera. And the arbitrary cutoff of a refractive error or axial length in the definition of pathological myopia carries very little clinical meaning. We've seen some clinicians automatically characterize anyone who has a prescription higher than -8 as pathological myopia, or an axial length of longer than 25.5 or 26 millimeters as pathological myopia. And however, we know in clinic, we've seen plenty of patients with prescription worse than -8 not showing any pathological changes. But at the same time, plenty of patients with prescription as low as -4 or -5 showing some very definitive retinal changes. Same arguments applies for axial length data. We've seen plenty of patients with an axial length of 26 millimeters, even not even myopic and as an ametrope. Or, someone like myself, with an axial length of 23.5 and already being a -3. So the point I want to make here is that there is a very significant individual variation of the axial length in association with refractive error. So an arbitrary cutoff of the definition of pathological myopia using either refractive error or axial length data is not very clinically meaningful. And another caveat of using this arbitrary cutoff of refractive error is actually it minimizes the consideration of the age-related component in the pathological myopia. When we're talking about this age relevancy, it carries two components. The first component is basically the pathological changes to myopia is accumulative on the already happening age-dependent degeneration of retinal and choroidal structure. And so -8 may have significantly higher risk of pathological myopia at age 40 as compared to the same level of myopia at age 10. And so we have to keep in mind that, for the same level of refractive error, as part of aging, the risk of developing pathological changes increasing significantly. And the second component to this age relevancy is merely the fact that right now we see myopia happening at a much younger age. And as we mentioned previously, the younger the onset of myopia, the faster the progression and the higher probability of someone ended up as a high myopia and eventually developing pathological changes. So if we take a look at the table below, we can see this is a table pretty much summarizing several cohort studies reporting the prevalence of high myopia and the prevalence of myopic retinopathy. And taking the two Chinese cohorts from 2010 and 2011, we can see the prevalence of a myopic retinopathy changed quite significantly, and that partially because the age composition of the two cohorts are quite different. So the younger the cohort, even with the same level of severity of myopia, the prevalence of pathological findings will be much less as compared to the same level of myopia observed in the older or elderly cohort. So I want to show you some changes, histological and anatomical changes that explains why myopia can cause irreversible vision loss. And I want to work our way from the outermost structure, which is the scleral structure, all the way into the retina. And the reason why I'm presenting the findings in this way is because essentially what we're seeing on the retina is actually originated from the decompensating changes from sclera. So once we have prolonged defocus signals or form deprivation signals reaching the retina, and there will be a series of signaling cascade generated from retina relayed by RPE and eventually reaching scleral structure. And in human sclera, the structure is a layer of very well organized, tough connective tissue that's predominantly fibrous. And the first response to the prolonged defocus signal, more specifically the hyperopic defocus to the sclera, is basically an increasing in its viscoelasticity, or in other words is extensibility that allows the intraocular pressure to extend the globe into a more posterior direction. And with the continuous stress to the axial elongation, there will be increased degradation of extracellular matrix and the loss of collagen and glycose, aminoglycan, as well as which basically results in the overall thinning of the sclera, especially posterior to the equator. And the thinning is most marked in the posterior pole. And it's important to keep in mind that this overall change, the scleral changes, at least in primate eyes, is irreversible. Meaning by the time we started seeing changes in the sclera, basically the elongation of the eyeball is going down path without ability to reverse this whole process. And commonly we've hear questions from parents asking, is there any treatment we can consider to totally reverse this process? And the answer is no. At least for human scleral structure, the changes is mostly a passive expansion related to the stress to the axial elongation. So once the eyeball reaches 25 millimeter, there is no way we can actually revert it back to a shorter length. And so this, I want to make this point because it's important to understand the earlier we start doing myopia control, the better or the more significant the accumulative benefit receive. So once the scleral structure reaching its elastic limit, it actually becomes stiffer or crispier, more brittle. And that's when in clinic we started seeing the scleral crescent and tilted disc, peripapillary atrophy, and the stretching and thinning of the lamina cribrosa. And with the continuous thinning of the scleral structure at the posterior pole, we will start seeing a posterior ectasia or the localized deformation of the scleral structure at the posterior pole. So with the advancements in imaging technologies such as OCT or ocular MRI, we're able to understand the anatomical changes related to pathological myopia much better. And we now know that at least with the exceptions of keratoconus or age-related cataract, almost all of the myopia is a result of excessive axial elongation. So which means with increasing severity of myopia, we keep seeing increasing in axial length and the eyeballs overall becomes more prolate. That is, the eyeball is longest axially and shorter in the peripheral direction. And more importantly, we now know it's not, especially for those eyes showing a lot of pathological changes, the eyeballs are not only just longer, but also showing a very significant localized deformation as we can see here. So the localized deformation or posterior ectasia, or as we've seen in B-scan or OCT, the posterior stathloma is serving as a much better predictor of atrophic maculopathy than using the axial length data or the overall vitreous chamber volume. Now, let's work our way in a little bit and take a look at the choroid and Bruch's membrane. Choroid is a very interesting structure. Before we start seeing the permanent changes on the sclera, choroid has, at least in primate eyes, have a temporary and minor mechanism of trying to minimize or eliminate the defocus signals before the permanent changes on the sclera happens. So with plus defocus or myopic defocus, the initial response of choroid is the choroid thickening, basically increasing in thickness. And conversely, with prolonged hyperopic defocus, there is marked thinning of the choroid. It changes from an average normal thickness of 250 microns all the way up to thinning to the 30 microns, so like 1/10 of its original thickness. And this mechanism is attempting to basically pull the retina backwards a little bit, transiently increasing axial length to minimize or diminish the defocus signal imposed on the retina. Once this temporary mechanism fails, there will be permanent scleral changes. So the overall and sustained marked thinning of the choroid structure basically reduce the distance between Bruch's membrane and sclera. And so sort of the choroid losing its buffering kind of role. And if we started seeing defects in the Bruch's membrane, basically is the break in the clinical presentation of lacquer cracks. It's really a bad sign. It's a poor prognosis. Lacquer cracks is one of the most important predictor of subretinal neovascularization. And we know Bruch's membrane is essential in maintaining the functionality of RPE cells. And so with the compromised Bruch's membrane, we will start seeing the loss of RPE cells and the choroidal capillaries. And we know RPE is essential to maintain the integrity of photoreceptors. So with compromised RPE layer, we will start seeing the loss of photoreceptors. And we know outer retina is the major source of VEGF factor. So once we started having delayed feeding or ischemic attack to the choroid layer, which is the major source for oxygen supply to the outer retina, there will be ischemic attack to the outer retina, which basically induce the secretion of VEGF factors, and that later on triggers the formation of choroidal neovascularization. So now let's work our way all the way into the retina. And the most common cause of permanent vision loss related to pathological myopia is the atrophic maculopathy. It typically is characterized by its slow progression, but it's almost always sight-threatening. Once someone started developing atrophic maculopathy, they will eventually have some level of vision loss. And the clinical presentation of atrophic maculopathy includes the atrophic changes of choroid, Bruch's membrane, RPE photoreceptors, and outer retina. And the most severe presentation of maculopathy related to myopia is the subretinal neovascularization formation, and it is currently the leading cause of blindness, and it's even ahead of that of a diabetic retinopathy. And unfortunately, this is still the only untreatable condition in the top 5 causes of blindness. We know with AMD, with diabetic retinopathy, with anti-VEGF injection, the prognosis of a preservation of vision is actually pretty good. Unfortunately, this is not the case for myopic maculopathy. And with uncontrolled or excessive axial elongation, we can also see some tractional maculopathy. And the most common type of the presentation of tractional changes is the retinal schisis in the macular region. That's the separation of inner and outer retina. And this presentation can be as a standalone presentation or can be associated with tractional macular holes as well. So in the next 3 slides, I'm showing you some very exciting data, and which negates a lot of the most traditional view of the risk of myopia pathology as a function of the severity of myopia. And this is a forest plot basically describing the risk of maculopathy as a function of the severity of myopia. And as we can see here, with increasing level of myopia, we see the risk of maculopathy increasing at an exponential level. But more importantly, I want to point out that you can see even at moderate level of myopia, that is the myopia from -3 to -5, the risk of maculopathy is 10 times higher than that of emmetropes or non-myopes. And this 10 times increase is not only clinically significant, but also statistically significant. This basically shows there is a very significantly increased risk of maculopathy even for lower level of myopia. So traditionally, especially for retinal specialists, they consider maculopathy is only a problem for a very high myopia. And this is not the case. And we know because even the risk increasing exponentially at a higher level of myopia, but because we have many more patients in the lower myopia categories, there is almost 50% of the maculopathy cases originated actually from lower myopia categories. Similar findings is observed in retinal detachment, and it's even more dramatic. Not only there is exponential increase in the risk of detachment with increasing myopia, And even for the lowest myopia category, that is from 3/4 up to -3, the risk of retinal detachment is both clinically and statistically significantly higher than non-myopes. And again, similar trend is observed in the risk of glaucoma and cataract. Even for the lowest category of myopia, there is substantially increased risk of glaucoma and cataract. And so the take-home message from this meta-analysis is that there is no such thing as physiological myopia. When we label something as physiological, that implies that it doesn't carry additional pathological like risk for pathology, which is not the case. And so there is no safety threshold or safety margin at lower level myopia. Once someone becomes myopia, they immediately have increased risk of the most common pathologies. And we now know low and high myopia carry similar etiology in terms of myopia pathology. And right now, myopia is the #1 risk factor for maculopathy and retinal detachment, and it is the second major risk factor for glaucoma and cataract, secondary only to age. And unlike other association studies where we cannot definitively draw a causal influence between the risk factor and the disease, in the case of myopia and its pathology, we actually have pretty strong evidence showing there is a causal linkage between myopia and the related pathologies. And the causal linkage has mostly two components. The first component is the temporal plausibility. And we know the onset of myopia usually preceded the onset of those pathologies by many years. And so there is no argument of which is chicken, which is egg. And the second component is that with the advancement in imaging technology, we have a very good evidence in biological, histological, and anatomical changes, basically underlining the exact mechanisms of how myopia cause those pathology. So what we can infer from the studies, the data from the most recent meta-analysis is basically showing there is no physiological myopia. There is either myopia or pathological myopia. Okay, so for the next 10 to 15 minutes, I'm hoping to show you some interesting data and hopefully to convince you that at least for school or juvenile myopia, we have good confidence. We have solid evidence suggesting it is the environmental factors that plays the predominant role, and the genetic factor is a susceptibility factor rather than a causal factor. And this is important to understand because if myopia is purely genetic or is predominantly genetic, then other than gene therapy, there is nothing you can do either by prescribing specialty novel optical devices or using eye drops that can slow the progression or change the endpoint of this progression. If it's all pre-programmed, the only thing that might be working is gene therapy, which is certainly not the case. So let's take a look at the nature versus nurture debate. And a lot of people refer to genetic studies and the high hereditary factor, using that as a group of evidence suggesting the predominant genetic influence in myopia. Here I want to emphasize that not all heritable factors are genetic factors. Taking an example, socioeconomical status, academic expectations, diets, all of those are heritable, tend to run a trend in the same family, but they are not genetic factors. In other words, the heritability in the genetic studies about myopia tend to overestimate the genetic influence of myopia. Second, we know myopia, even though its clinical presentation is simple, it's basically just the image is falling in front of the retina. But we know myopia in general has a very, very complex phenotype. There is early onset or congenital myopia, which can be part of a syndrome. For example, Marfan's, Stickler's, Usher's. Or it can be as a simple, more simpler disease such as school myopia, later onset myopia, or juvenile myopia. So we can't really take all of the myopia phenotypes into a simple, oversimplified classification. Here we're mostly targeting at school myopia or juvenile myopia, which tends to happen several years after birth and is started at a lower level and tend to be progressive. And so the next group of evidence about the genetic influence of myopia is from large super sample size GWAS studies. That's the genome-wide association studies. So far, there have been about 25 genes that have been identified to have an association with refractive development and myopia. However, all of these 25 genes together couldn't even explain more than 10% of populational myopia. This basically suggests not only all of them together carries a very small effect size, and each one of them is not a causal gene. They are susceptibility genes. A simpler way of understanding the susceptibility factor versus a causal factor is that if someone is carrying a lot of myopic genes, the same amount of prolonged near work or near stress will be much more likely to cause the development and the progression of myopia as compared to someone who doesn't have those genes. But it is ultimately how they use their eyes, the intensity of near work that cause the eyes to become nearsighted. Carrying those genes merely just increase the susceptibility of the eyes responding to those environmental factors. And the last point about this argument is there is no simple theory explaining the etiology of myopia. We now know that there is extremely complex gene-gene and gene-environmental interactions in the etiology of myopia. So let's take a look at the influence of environmental factors. There are three groups of evidence we can use to argue strongly that juvenile myopia is predominantly affected by the environmental factors. The first group of evidence is the populational studies on the prevalence of myopia. We now know myopia, the increased prevalence of myopia is a worldwide trend, is not just specific to one ethnicity or one country. And it has been estimated that the overall increase in the prevalence of myopia is about 1% every year. So this drastic increase in the prevalence of myopia worldwide is a strong piece of our argument against the genetic factors, because we know genetic makeups doesn't change in such a fast rate. And the second group of evidence is basically from previously discussed GWAS studies. Even though there are multiple genes, up to 25 genes identified to be associated with myopia development, we do not yet have one causal gene identified. They're all susceptibility genes. So they play a role in the development of myopia, but they're not causal genes such as breast cancer 1 or breast cancer 2 gene in the development of breast cancer. And the third group of evidence is from experimental models or animal models in myopia. We can show that in almost all of the species that's been investigated, the plus or minus defocus and form deprivational signals reaching the retina is very precisely regulating the elongation of the eyeball. And so this strongly suggests by manipulating the optical environment in which the eyeballs are developing, we can totally change the course of emmetropization and the endpoint of emmetropization. So with those evidence, I hope we can comfortably discuss with patients and parents that myopia, at least in the subcategory of juvenile or school myopia, it is not only controllable, treatable, and we should really start early. And so I want to take the last 10 minutes to give us a brief overview of what are the available options for myopia control. When we talk about myopia control, sometimes we jump right into the optical or pharmacological options. But keep in mind that myopia control has to be multifaceted and has to start early, and it starts with behavioral modification, meaning we need to change how the kids spend their time every day. And from the previous public health data, we can see it's equally important to delay the onset of myopia. If we can prevent it from happening at all, the slowing down the progression of myopia and controlling the overall severity of myopia is equally important as preventing the onset of myopia. And as we mentioned earlier, at least for human eyes, the scleral structure, the elongation of the eyeball, is an irreversible process. And so early intervention is the key. The earlier we start the prevention and the treatment of myopia, the better the cumulative benefit each individual patient will perceive. And in terms of the lifestyle change, I want to make a point that the commonly recommended 20-20-20 rule does not work. The 20-20-20 rule basically says every 20 minutes of reading, you need to take a 20-second break, and you need to look at 20 feet or further. And in metric system, it's basically like 6 meters or further. And this doesn't work for two reasons. One, for retina to detect the defocus signals in the correct direction. In primate models, we know it takes minutes, somewhere between 10 to 15 minutes, for monkey eyes to detect whether the retina is under a hyperopic or a myopic defocus. So 20 seconds of break from near work is not nearly good enough for the retina to detect the signal and to generate the correct response. And the second component why this 20-20-20 rule doesn't work is that we know not only central vision is critical, but peripheral vision is also critical in the role of emmetropization. Even though we can manage a central vision of beyond 6 meters, and in the indoor environment, most likely the peripheral vision will still be crowded by the wall structure, by the ceiling, by the floor. And so we need to really promote outdoor activity. And exactly how outdoor activity is protective against the development of myopia is still unclear. It could be a combination of light intensity, a specific light spectrum that's serving as the protective role, the change of the balance between sympathetic and parasympathetic system. A lot of factors may play a role together, but what we do know is outdoor activity is protective against the development of myopia. So managing myopia started from lifestyle modification, behavioral modification. And currently the evidence-based treatment options for myopia control can be classified as the optical treatments or pharmacological treatments. When we're talking about evidence-based, we're mostly talking about repeatable clinical trials in solid study design showing consistent evidence rather than just sporadic case reports. So in the optical category, we know 3 types of lenses work in showing clinically and statistically significant effect in myopia control. Those treatment options include ortho-keratology, most likely in the overnight wearing modality, multifocal contact lenses, both in the form of soft multifocal lenses or rigid multifocal lenses, and also in spectacles, the peripheral defocus designs. And in the pharmacology mechanism, there has been reported with low-dose atropine showing a significant effect in myopia control, and pirazapine, which is unfortunately pre-discontinued due to the manufacturers not seeing the market potential for this drug in myopia control. And in Europe, there has been reports of oral 7-methyldancine showing significant effect in myopia control. So in the interest of time, I don't want to get into the details of low-dose atropine and or pirazapine in myopia control, but I do want to see if we have some questions related to the risk of myopia pathology or any clinically relevant questions related to the optical management of myopia. Thank you.
Thank you, Dr. Liu. Are there any questions this morning? Okay, well, if you do have a question and you would like to send it to me, we will see if we can get that answered. Oh, and okay, we do.
Okay, the first question I have here is, which treatment modality do I think is most successful? So certainly, let me go back to the treatment modality here. Here I'm presenting the cumulative evidence from publications, not my personal opinion. Currently, it has been suggested that overnight orthokeratology and multifocal contact lenses are comparable, showing comparable efficacy in myopia control. From a populational standpoint, they both slow down the progression of myopia for about 50%. However, the efficacy related to Ortho-k has bigger individual variation. The standard deviation related to the efficacy of Ortho-k varied from 30% to 70%. And in multifocal lenses, the data seems to be more clustered around that 50% average. And we all know that in terms of candidate selection for Ortho-k and multifocal lenses, this is definitely a multifactorial decision. It depends on the motivation of wearing contact lenses and the age and the severity of myopia. If we're talking about 6 years old, usually parents are more comfortable with Ortho-k option because the insertion, wearing, and removal of the lenses are all happening at home under the oversight of parents, versus daytime daily wear contact lenses, kids needs to be at least safely remove contact lenses in case something happens to the lens or happening to the eye. And so if we're talking about a younger age, younger patients, Ortho-k tend to be a preferred option than multifocal lenses. But in terms of the efficacy, they're both pretty comparable. And low-dose atropine, the data from for low-dose atropine mostly from Singapore, and currently they have a 5-year longitudinal data combining ATOM-1 and ATOM-2 study, including 1 year of washout, understanding the concentration-dependent efficacy of atropine. So far, the conclusion is if we're talking about a range from 0.01% all the way up to 1% for 5-year data, lower concentration, 0.01% and 0.05% actually has better prolonged or sustained myopia controlling benefit as compared to a higher concentration, such as 0.5% or 1%, mostly because the higher the concentration of atropine, the more significant the rebound effect. So for 1% atropine, during the phase, subjects are actually using the drop. There is literally no progression of axial elongation or refractive development. However, during the 1-year washout period, the rebound effect is so significant that it almost negates the whole controlling effect of 1% atropine, versus 0.01% atropine, even though the onset of its controlling effect is slower, but it doesn't show nearly as much rebound effect when you discontinue the lower concentration. And for 5-year data, it showed about 30% axial slowing of the progression of myopia with 0.01% atropine for 5-year data. So if we have some time, I really want to emphasize the take-home message. The take-home message basically, I really want to, show that myopia is a worldwide epidemic, and with a faster increase in the high myopia category, as we mentioned before, the risk of myopia pathology increasing exponentially with the severity of myopia. And with that said, there is no such thing as physiological myopia. No myopia is safe. And we know maculopathy, retinal detachment, glaucoma, cataract, the risk increase significantly even at lower level of myopia. And another important message I want to deliver is that myopia is not just genetics. Environmental influence plays a very critical role. Although there is very complex interactions between gene-gene interaction and gene-environmental interactions, we have good evidence showing by manipulating the optical environment in which the eyeballs are developing, we can change the course of emmetropization and change the endpoint of the emmetropization or myopia progression. And so related to that, I want to conclude the presentation that myopia is controllable, and because for human myopia, the axial elongation is irreversible, so early intervention is the key. And it requires multifaceted approach for each individual patient, the severity of myopia, the age of onset, parental history of myopia, their motivation for contact lenses, their lifestyle, their visual demand. All of these factors play a role in deciding what would be the best approach for that kid at what age. And another point I want to make here is that the more we study myopia, the more we understand we do not know the exact mechanism of how each lens or each treatment option is working in slowing down the progression. We know it has something to do with how the optical environment is being manipulated, but it's not simply by one mechanism. It's more likely to be multiple mechanisms working together. And currently we do not have standardized protocols in either the optical corrections or pharmacological treatments in managing or slowing down the progression of myopia. Thank you.
Thank you very much, Dr. Liu. We certainly appreciate you showing your presentation today, and we all enjoyed it. There were quite a few questions we didn't get to. We'll see if we can answer them via email. The next webinar will be held on Wednesday, July 27th at 8 a.m. as well, and it's Maximize Your Ortho-k Practice. And the presenter will be Ken Kopp, the Director of Clinical and Professional Services at Paragon Vision Sciences. We would really appreciate any feedback that you can give us. There are several email addresses. We certainly appreciate your attendance. And again, Dr. Liu, this was fantastic. Thanks. Thank you, everyone in Australia, for getting up so early. We're ready for dinner now. Have a good evening. Good day.
Thank you, Angela.